Welcome to This Explainer. Today, we're diving into a medical detective story that is just, well, it's pretty tragic, but it's absolutely fascinating. We're looking at a case that completely turns oncology on its head. It challenges the fundamental way doctors understand, classify, and ultimately treat one of the most fatal forms of breast cancer. What we're unpacking here isn't just a rare medical anomaly, it's a massive, urgent call for a paradigm shift.
So, to really grasp why we so desperately need a paradigm shift here, we've got to ask ourselves a fundamental question. What actually happens when a disease just refuses to play by the rules? What happens when the established playbook that physicians have relied on for decades suddenly leads them straight to a dead end?
All right, let's get right into the evidence. Take a close look at these CT scans. We have a 67-year-old patient who came into the ER in severe distress. And what we're seeing here is honestly terrifying. It's diffuse carcinosis. The cancer has spread so wildly that it's infiltrating deep abdominal fat, literally compressing her major blood vessels and blocking her ureters, which, led to a severe swelling of her kidneys called bilateral hydronephrosis. This incredibly aggressive presentation sent the medical team into an absolute scramble to try and find the primary tumor. Section 1. Searching for the source.
And you know what? They almost missed it entirely. Looking at these scans, the standard mammogram is completely obscured. The patient had prior breast reduction surgery, and the extensive scarring created this intense architectural distortion. It totally hid the primary tumor from the human eye. It wasn't until they went back and ran an AI algorithm, which you can see highlighting the lesion, that they finally flagged this hidden abnormality in the upper outer quadrant of her left breast.
So, armed with that AI flag, the medical team brought in multimodal imaging, MRI, ultrasound, the works, to get a clearer picture. And what they found was a massive, highly stealthy, multifocal malignancy stretching over 50 millimeters, plus pathological lymph nodes. We're not talking about a small, isolated lump here. This was a vast, sprawling network of disease hiding in plain sight.
They do a biopsy, and the diagnosis comes back as classic invasive lobular carcinoma, or ILC. That's the standard World Health Organization terminology. Naturally, this sets the stage for your typical conservative therapy. But, as we're going to see in just a second, this exact terminology, it might actually be the root of a massive, systemic failure when it comes to treating this specific cancer.
Which brings us to Section 2, an unrelenting, unusual spread.
This timeline right here really lays out her tragic journey. 2 years post-diagnosis and treatment, the patient develops a large metastasis in the perianal region. Now, breast cancer spreading there, highly unusual. Then, just 17 months later, she's hospitalized for acute appendicitis, except it turns out the breast cancer had metastasized straight to her appendix. Ultimately, 3 years and 10 months after her initial diagnosis, she tragically passed away from this relentless spread.
If you want to understand the sheer, unstoppable force of this spread, just look at the tissue itself. We've got the perianal mass histopathology showing massive infiltration. And then there's the cross-section of her appendix. The cancer didn't just touch it, it totally took over the entire wall, causing gangrenous inflammation. Looking at these microscopic slides, you really get a visceral sense of how uniquely and aggressively this breast cancer attacked her GI tract.
So what's driving this? Well, a major clue is right here under the microscope. Look at how these malignant cells are growing. They aren't bunching up into your typical solid spherical tumor mass. No, they're marching in these single files. Literally single rows alternating with newly formed fibrous strands. This excess fibrous tissue causes the firm, diffuse thickening doctors feel during an exam, and it perfectly matches the imaging biomarkers we saw earlier.
And just to be absolutely certain they weren't dealing with a brand new GI or bone cancer, the team ran specific immunohistochemical markers. See that brown staining on the bone and perineal biopsies? Those are positive reactions for markers like GATA3, CK7, and estrogen receptors. Basically, this biomarker profiling proved beyond a shadow of a doubt that these bizarrely located tumors absolutely started in the breast.
Let's move on to Section 3, the naming problem. All right, this brings us to the core scientific paradigm shift the authors are proposing. They're arguing that the current WHO terminology, classic invasive lobular carcinoma, is not just outdated, it's anatomically incorrect and incredibly misleading. Instead, they want to rename this diffusely infiltrating subtype to breast cancer of mesenchymal origin, or BCMO.
Why make such a big deal over a name? Let's break it down. The word lobular inherently implies that cancer starts in the epithelial cells of the breast's lobular acini. But here's the kicker. Cell culture studies show those acini cells are perfectly normal in this malignancy. The true origin? It actually lies in pluripotent hybrid stem cells. Those are the master cells located in the connective tissue right outside the lobules, the extralobular mesenchyme. It's an entirely different starting point.
And that takes us to our final section, Section 4, a call for new cures.
Listen, distinguishing between an epithelial cell and a stem cell, that is definitely not just academic semantics. It is quite literally a matter of life and death. Because we've misidentified the origin with the word lobular, the medical community has spent decades treating a stem cell-derived cancer with drugs designed for epithelial cancers. It's like trying to fix a massive plumbing leak with electrical tape, right? The tools are completely useless because we completely misunderstood the problem.
The study authors wrap up with this incredibly urgent, powerful plea. They literally state, the medical community has been barking up the wrong tree, and that it's past time to acknowledge this massive failure. Think about it. The long-term fatality rate for this specific subtype hasn't really budged in over half a century. Until we classify it correctly, researchers won't even know to start looking for the specialized, targeted therapies we actually need to fight a stem cell-based disease. This tragic but honestly illuminating case leaves us with a pretty provocative final thought. Words matter. The names we give things absolutely dictate how we understand them. So, if the very words we use to diagnose a disease can actively prevent us from curing it, what other medical mysteries are out there right now, taking lives, just waiting for a simple name change? Thank you so much for joining me on this explainer. Keep questioning, keep learning, and I'll catch you next time.